All right, welcome back to our deep dive on identifying stroke risk in the dizzy patient. This is the final part where we bring it all together. We've talked about the anatomy, we've gone through the hints plus exam, and now it's time to put it all into practice. We're going to walk through a really clear triage algorithm, talk about the critical blind spots of imaging, and give you the exact framework you need to document and discharge your patients safely. So let's dive right in.
So let's start with the most critical question. And it's not, does this patient have a stroke? The real question, the one that should frame your entire approach, is this. Is this acute vestibular syndrome, peripheral or central? You know, if you can answer that one question correctly at the bedside, you've pretty much solved the whole puzzle.
And look, getting that question wrong, the stakes are just incredibly high. We're talking a diagnostic error rate for posterior circulation stroke of a staggering 30 to 50% on that first visit. That is way higher than for strokes in the front of the brain. And missing this isn't a small thing. It carries a 7-fold increased risk of stroke or death within just 30 days.
This brings us to a really powerful and honestly life-saving paradox. When a patient is absolutely floored by vertigo, truly miserable, you expect to find really obvious peripheral signs. Bad nystagmus, a clear head impulse deficit. If you don't find them, if the exam seems strangely normal, that's not reassuring. That absence of findings is itself a massive red flag for a central cause.
So how do we keep from falling into that trap? Well, you do it with a structured algorithm. This isn't about guesswork or just a gut feeling. It's about a systematic approach you can use right there at the bedside to figure out who's high risk and who's not. Okay, step 1. This is your rapid screen for the really obvious stuff. You're asking, are there any new focal signs? Weakness, numbness, double vision? What about a new bad headache in the back of the head or neck pain? That could be a dissection. Is their balance way worse than their dizziness seems to explain? And finally, what's their background? Being over 50 with vascular risk factors automatically bumps up the suspicion for stroke.
And I want to be crystal clear about this. If the answer is yes to any single one of those questions, you stop. That's it. This is a non-negotiable, immediate transfer to the emergency department for a stroke workup. There is zero room for hesitation here.
All right, but what if that initial screen is negative? They don't have any of those major red flags. Now what? Well, now you bring out the big guns, your most powerful tool, the hints plus examination. This is really the heart of the bedside assessment for these patients. And your next move totally hinges on how you interpret this. If every single part of the test points to a peripheral cause, and you're an experienced clinician who feels confident in what you found, then sure, you can manage it as peripheral. But listen, if anything at all looks central, that's the infarct pattern. Or if you're just not sure, maybe the results are a bit muddy, that's not a green light. An equivocal hints exam is an indication to escalate or get imaging, period. Now, speaking of imaging, this is so important. We're all trained to think of scans as the ultimate truth teller, right? But the reality is, in acute vertigo, they have some really dangerous blind spots. And this is exactly why your clinical skills, especially that hints plus exam, are absolutely vital.
Just take a look at these numbers. A non-contrast CT scan has a sensitivity of about 16% for a posterior fossa stroke. That basically makes it useless for ruling one out. Even an early MRI, the supposed gold standard, can miss up to 20% of small brainstem strokes in the first 2 days. Now compare that to the hints plus exam, with a sensitivity approaching 99%. Let that sink in. Your hands and your eyes are more sensitive than an early MRI scan.
Let's just hammer this point home, because it's that important. A CT scan is going to miss about 84% of these strokes. Its only real job is to rule out a bleed. And you have to remember this. A normal MRI in the first 48 hours does not mean there isn't a small brainstem stroke. So if your gut, backed by your clinical exam, is screaming stroke, you trust your exam, not that early scan.
This brings us to the really tough cases. The patient with just vertigo, a pretty normal-looking exam, where even a confident hint might be misleading. These are the ones that get missed most often. But there are specific red flag patterns, mostly in the patient's story, that have to override everything else and trigger an immediate escalation.
These are your absolute non-negotiables. You're looking for that story of vertigo that hits like a thunderclap. Boom, maximum intensity from the get-go. Any new pain in the back of the head or neck should make you think about a vertebral artery dissection. Severe truncal ataxia, where they literally can't even sit up or stand without support, that screams cerebellum. And of course, brand new hearing loss in 1 year. That points straight to a possible stroke in the ACICA territory. Okay, so you've done your assessment, you've made your call. But you're not done. Not by a long shot. The final steps are arguably the most important, both for your patient's safety and for your own medical legal protection. We're talking about a safe disposition, clear documentation, and structured safety netting.
So, the path you take next depends completely on the diagnosis. For a stroke, it's all about time-critical treatment. For vestibular neuritis, it's short-term meds and then getting them moving with rehab. But I really want you to look at that middle point. Any confirmed cerebellar infarct must be admitted to a service with neurosurgery. Why? Because they can swell and herniate, and that's life-threatening. This is an absolute, unbreakable rule. You never, ever manage a cerebellar infarct as an outpatient.
A good medical legally sound note tells the story of your thinking. It shows not just what you found, but what you thought about and ruled out. Writing a HINTS exam performed. Head impulse abnormal right, unidirectional nystagmus, no skew, consistent with peripheral pattern, is infinitely stronger and safer than just scribbling vertigo, likely peripheral. This checklist just makes sure you cover all your bases.
And finally, every single patient you send home with a probably peripheral diagnosis needs this safety net. You have to give them explicit, crystal clear instructions. You have to tell them you need to come back immediately if you get a new headache, neck pain, double vision, anything like that. And just as critically, you need to schedule a follow-up. A diagnosis without a plan for review is an unsafe, incomplete encounter.
Okay, we've covered a ton of ground here, so let's boil this whole thing down to 3 essential, practice-changing rules that really summarize this entire explainer. Rule number 1, trust your exam over an early scan. A normal CT scan does not rule out a stroke. It just tells you there's no bleed. That's it. And even though MRI is the best we've got, it can be falsely negative in those first couple of days. Your clinical assessment is your most sensitive tool in that acute window.
Rule number 2, respect the history. Those high-risk patterns we talked about, the thunderclap onset, the neck pain, the severe ataxia, they are incredibly powerful. These red flags should make the hair on the back of your neck stand up, and they demand you escalate, even if the rest of your exam seems fine. And number 3, a safe discharge is a 2-part deal. They are inseparable. You must have detailed documentation that shows your reasoning, and you must give the patient a structured, explicit safety net with a follow-up plan. One without the other is simply not good enough.
And that right there, that really sums up the entire philosophy of this whole 3-part series. The core question, is this peripheral or central? That's answered at the bedside with your clinical skills. You escalate based on patterns, you image when you need to, and you only send a patient home when you've put a solid safety net in place.
So I want to leave you with this question to think about. For your own practice, when that next dizzy patient walks through your door, what's the one single thing from this algorithm that you are going to laser focus on implementing first? Is it the HINTS exam, the documentation, the safety netting? Think about it.
And that's a wrap on our 3-part series on acute vertigo and stroke risk. Thank you so much for joining us. For more resources like cheat sheets and detailed articles on this topic, please visit us at australiandizzinessclinics.com. And if you found this series useful, we'd really appreciate it if you'd subscribe and leave a rating.